coming in.
Fantastic. Thank you, everybody who's able to join live. Looks like we have a nice little group here that's going to be able to join the conversations, but we are recording the session and there'll be tons of you watching this, a non-live live version of this. So thank you and welcome, everyone. So this is what we're calling episode number 2 of our Connected Conversations. Super excited to have you here today. Just to frame for everybody, as we did in our first episode, introduce myself. My name is Lisa Schaffer. I am the chair of the Patient Engagement Committee, or the Public Engagement Committee, pardon me, of Obesity Canada. So I get to help work with Obesity Canada. I've been volunteering since 2017 to really try and disseminate information. And it is my pleasure to have my sidekick here, Ian Patton. If you want to introduce yourself briefly, feel free.
Sure. So, hi everyone. I am the Director of Advocacy and Public Engagement with Obesity Canada. I've been with the organization for over a decade now. I started as a student and trainee when I was doing my my PhD and postdoc work, and I volunteered with Obesity Canada back then. And through my own personal lived experience, I'm someone who ended up having bariatric surgery and kind of living on both sides of that fence of both the academic side and the lived experience side. I ended up kind of becoming very passionate about patient advocacy and working with Obesity Canada. And so now that's what I do full time.
Love it. And part of what Obesity Canada has been working on for the last few months is setting up these ancillary communities online called Connected. So we have Connect Pro and OC Connect. And OC Connect is where our patient community is growing and thriving. We're sharing a lot of information. Ian and I are very passionate about making the next generation of patients. And then in OC Connect Pro, we're working on disseminating information and connecting with healthcare professionals to, again, create the next generation of what we believe can be an amazing healthcare community. So to that end, we decided we needed to have some blended conversations, and we have created these amazing connected conversation moments. So our episode today, we are going to be talking about innovating obesity care in Canada, which is going to be a really interesting conversation. We have a little bit of a small group here. Did we figure out polls? Should we ask that question still, Ian? How do you feel? Oh my gosh, look at us.
There we go.
What a time to be alive. So we would love to know who's in the room here today. So those of you that are here, if you could help us by just telling us, which audience group do you identify with? Do you come to us from a healthcare professional field, a person living with obesity, or possibly you are a support person or a family member of someone living with obesity? Or you might not fit into any of those categories. So just let us know how you kind of identify. Just helps us know who's in the room. But regardless, we feel like we're about to have an amazing conversation that's going to help benefit a lot of people. Awesome. So while those poll results are coming in, I'm going to go ahead and introduce the lady of the hour, which is probably why most people are here. So it is our amazing privilege to have Dr. Ali Zentner on the call here with us today for this amazing conversation. So Dr. Zentner has built an amazing practice out here in Vancouver, British Columbia called Revolution Medical Clinic. And she serves as the medical director. The clinic has been recognized as a center of excellence by the European Association of Study of Obesity. It's one of the largest multidisciplinary clinics in Canada, and it is run exclusively through the socialized healthcare system. Hence the amazing portrait of Tommy Douglas behind Dr. Zentner as well. Dr. Zentner is also the founder and director of the Canadian Obesity Peer Support Program, and that's an online program we're going to talk a little bit that offers peer support educational information for clinicians wanting to learn about obesity, which they should all be wanting to learn about obesity. The program has trained over 600 clinicians in a peer support setting, which is just amazing. Ali is also the founder and director of the Obesity Project, which has an amazing website called nofatshame.com. It's a multi-level educational program that addresses weight bias in medicine. And the project also involves patients and clinicians together and educates medical trainees, doctors, and nurses on weight sensitivity and bias. It also really empowers patients to understand what weight bias looks like and how to kind of call it out. So lots to talk about, lots of influence. And again, thank you so much for joining us this morning, Dr. Zentner.
Thanks for having me.
Yeah.
And Ali, please.
Okay, deal. I can go there. I can go there. Awesome. So do we have poll results you want to share at all, Ian, before I tuck into the first
Yeah, it
question?
looks like there's about 50% were the healthcare professionals and another 35-ish% were people living with obesity. And then there was a couple others in there as well.
That's awesome. So thanks everybody for making the time today. We will also have moments where we can ask a couple questions to Dr. Zentner. So we do have a chat function. I just want to call that out as well. Ian will help moderate over there. So if we have questions for Dr. Zentner, we can post them there. And as time permits, we'll go there in the conversations. But what we really wanted to start with is we can see and we can sense, we know we're a little bit close to this, that we're getting a little traction. I feel like we're getting some traction here, and that we can see that obesity management is really evolving and we're learning more. And as Ali likes to say, when we know better, we do better. But I'd love to know from your experience, Ali, like working in this field, I'd love to know how you got into this field a little bit, but also what have you seen? What are the changes that you've seen in practice, in options for treatment, all of those kinds of things? A little snapshot from your perspective would be really interesting.
Yeah, I mean, I've been in practice since 2000. And actually started off in cardiology and then left cardiology for internal medicine and decided that, wow, I really, it was one of these, I think almost every doctor in Canada who works in this space can tell you, at least the ones who've been around for maybe 4 years or more, that it was by accident. And I know that doesn't sound very sexy, but we all came upon it sort of as a happenstance, if you will. And for me, not to monopolize the nature of our conversation, but it was one of those happenstance moments, and realized very quickly that this was a wonderful space that kind of met my own social justice warrior needs, in addition to, it was every aspect of medicine. It was the science, it was the clinical care, it was the emotional sort of holistic approach to a patient. And then also, of course, it was patient advocacy. And those were the areas that I think initially kind of drew me to to fall in love with medicine. I would say, I think when I think about how obesity medicine has changed in the last, let's say 20 years, which is probably a good benchmark, I think that we start with the science. When I was going through medical school, fat tissue was something that kept you warm. And we didn't even really acknowledge that fat tissue was a storage space. It was more just an insulation kind of type picture. So from a physiological perspective, we didn't really understand its role, which, if you think about it, is kind of insane, that there was this whole organ system that was kind of just misunderstood. Absolutely. And by the same token, it sort of spoke to the broader sense of medicine, and hint on medicine. And I'm sure my medicine colleagues would agree that, unfortunately, in medicine, when we don't understand the science, we tend to take the information from wherever it is. So, if we don't understand the science, we go to the culture. And that's really what's happened in obesity medicine. And we have really sort of by default adopted dieting culture into our practices. And it was definitely far more significant 20 years ago. And make no mistake, it's still heavily prevalent now. But I would argue that, we almost need to de-diet medicine. And so what I have seen is a very slow beginning, I think. I don't think we're anywhere even at the halfway mark of a slow glacial de-dieting of medicine because of, and yes, Lisa, you can have that term.
I'm going to, can you tell I'm writing it down?
Of medicine, because science has sort of found a space in it. The problem is that the dieting culture, if you will, holds such a prevalent space in our everyday, that, you know, even though science is sort of the laws of nature, you know, it's still not what people believe. So even though science is what we know, often what people believe, or the dieting piece, all, you know, takes huge prevalence. I've seen, you know, the change occurs in all different levels. So I've seen a change in terms of treatment. There's definitely way more treatment options available. I was always shunned as the doctor who loved drugs. I mean, I remember that even among my colleagues nowadays who are like, you know, who've come on board, that, you know, I always used to get, why do you like drugs so much? I'm like, I'm a doctor. Like, we did go to school to write prescriptions, like, you know, make no, well, and there was this implication that if you gave drugs and you didn't talk to patients, like, it was just, you just handed out drugs. And I was like, let's be clear, like, I do have conversations. And so, you know, this idea that I think there are more treatments. I have always been a fan of treatment. I have always profoundly thought that, you know, physiologically, patients need a physiological advantage of some kind, whether it's medications or surgery, or in many cases, both. I mean, I'm a physician. That's what I do. I'm actually no longer apologetic for it. I would say a decade ago, maybe I was a lot more, dare I say, timid about being aggressive with treatment. But I think that patients come to see me because whatever they're doing outside of the medical space is not effective for them. So I think there's that. So I've seen that kind of treatment growth happen. I think that that has a positive and a negative with it. The positive, of course, is the fact that, you know, with every treatment, there is a cracking of the ceiling, if you will, and we keep pushing it. However, there's still this constant defending of the guard, which is very, it's very odd, and it has to likely do, you know, there's probably multiple factors of it, but there's definitely a cultural integration of it. So I think there's pushback on both sides. There's the pushback from the, you know, from the medical community over the fact that, well, you know, like, really, you know, let's do it the natural way. And I don't understand this natural argument, because everything that I know about natural is bad. So sorry, like, cocaine is natural, viruses are natural, you know, death is natural. Like, I just don't feel medicine is natural. Medicine is cheating death. Like, medicine fights to not let the natural happen, you know. So I think that there's that. And then there's also pushback, I think, from sort of culture, and with the onset of social media and all of that and the internet, there's this criticism over what is called the medicalization to use the terminology, the medicalization of fat. So I critique the dietization of medicine, and then there's the medicalization of sort of size. And I have to say, I think that that medicalization argument has validity to it. And I constantly, I would say now in my practice, try and find a way to marry the two and come up with, you know, I think our next phase of medicine will be, how do we, you know, find a better way to not medicalize everyone and to appropriately, effectively treat those patients. And I mean, I have some pretty big ideas about what that is, but I would argue that it involves literally deconstructing the entire tower, if you will, and building a different construct. And I think there's some problems there.
Yeah, that's a big undertaking. Ian, you
Yeah.
look like you have words that you want to say.
Yeah, I was there was something that when you were initially talking about the treatments and stuff and how you're, pro treatment and stuff like that came to my head, and it was, from my experience, and I'm someone who has used medications as part of my treatment for obesity, and you know, you were saying how it's not natural and stuff like that. But for me, what was not natural was how I was feeling prior to taking those medications. So like I couldn't explain how my food brain was out of control and all that stuff to my peers who aren't living or experiencing this disease. And so like what I was experiencing was unnatural. Now that I have my treatment, and it's not an easy fix. It doesn't solve the problem, but it allows me to feel normal, natural. Like I can be like all my other peers, and I can, treat food and activity and all my behavioral stuff. I have the capacity now to do all those things, like I see my peers doing who aren't living with obesity. I feel more like what I imagine a normal person would feel like with that treatment. So I think that there's some, it's been really powerful and innovative with some of these new treatments that are coming out. But, how do we change that kind of opinion about treatments for patients and for doctors who are going to be prescribing it? Like, how do we change that from it being like a simple fix, cheating, or you're taking the easy way out, and you'd be better off just doing it on your own, which is what a lot of us experience.
So I think a couple of things. First of all, I think language matters. We have talked about this, Ian, as an aside. I am a big fan of language. As a complete aside, I'm on my own path of truth and reconciliation and learning a lot about it, and have had discussions at different levels about the word decolonization. And I have friends who are like, that's a very harsh word. And I'm like, get comfortable with being uncomfortable. Like, sorry. So I think one, language matters. It's interesting, Ian, and I'm not going to correct you, but you use the term normal. And you notice, like, I was like, whoa, like, yeah. What is, right? Like, normal is just a weird, like, we need, like, get rid of the word. Like, what is that? Like, in fact, I would argue, like, normal versus so were you abnormal? But, and the problem I have with the word normal is that it implies that obesity is a behavior. And it's not. Obesity is an endocrinopathy or a hormonal imbalance where the brain thinks it's starving, and it engages in pure physiological response. Starvation response it involves storing food and hunting for food. So, food cravings and food thoughts are because the brain thinks it's starving. And so a starving brain that is inappropriately thinking it's starving will have more food thoughts. So patients, and again, so there's that piece. So language matters. I've talked about this at the Obesity Canada conference. I don't like the word obesity. I hate it. If you knew what it meant, you guys would change your name. Do you know what obesity means? It's from the French and the Latin, which means to eat oneself fat. Anyone love that name? I think it sucks. So I like the name adiposity, right? And I think, I mean, make no mistake, I've never used, if you look at my clinic website and that, sure, we talk about obesity. And I think it's one that yes, we talk about person first language, and that has evolved. But I would argue, when I talk about sort of breaking down the foundation, I think we ought to change our name, because we literally are living under an umbrella term of probably 50 different diseases, right? I think a glossary of terms. When I say disease, patients, I watch them do this. A disease does not mean one is sick. It means that the body physiologically doesn't do its intended function, not normal function, and that can affect how a person moves through the world. And that can be because the dysregulation, for whatever reason, affects the world, or that the world just doesn't accommodate their dysregulation. So there's that. So I have an issue with that. I think that our way of measuring, like our entry point for this is wrong. It's colonial. I mean, I constantly read journal article after journal article talking about how the BMI was established in the 1800s by a white guy in Northern Europe who was an astrologer who wanted to measure mass on the planet. And he uses the Flemish and the Scottish army in pursuit of the perfect man. And we use that in science without any confirmation, without it. It was literally, well, we have nothing else. So, and that's like the hydroxychloroquine of medicine. Like, well, we don't have anything else to treat COVID, so let's just use that. Like, that just seems stupid. Like, I'm just going to say it plain. And it also is the most unscientific thing. So number one, our name sucks. It literally flies in the face of everything we're trying to fight against. So you tell people not to be biased. You tell colleagues not to be biased. And yet you name your patient to eat oneself fat. Like, I don't know about you guys, but I'm just like, okay, good luck. Have fun. Stay safe. There's that. Number one. Number two, you create a point of entry into this disease that is, we all agree, is completely flawed. And then so no wonder you're going to continue to allow the dietization of medicine because you're not relying on the science for diagnosis. And so if you don't rely on science for diagnosis, then how can you rely on science for treatment? Because you've already screwed the pooch that way, so to speak. So that's two that I think has to happen. And then you expect people to be enlightened and not be biased when you've already literally set them up with two major biases with just how you're calling it and how you're diagnosing it. And so there's the problem already. So I think and I've always was taught by my teachers that if you see a problem, please come up with a solution. It doesn't have to be the solution because don't just complain. So my feeling is we could change the name and we could stop using BMI once and for all. Like, let's just not even explain it. Let's just stop using it. Mm-hmm. Like, let's stop. Or if we're going to use it, can we not have 30? Like, I don't get the 30 thing. Or can we at least look at, I don't know, an ethnocultural male, female, like maybe do a little bit of that? Like, could that at least be part of it? So I think that there's that piece to it. So those are, I guess, to your point, Ian, kind of, I think, our starting points. And, when we talk about where we've come from and where we're headed, I can honestly say that I don't think we're going to make the inroads we hope for if we still carry that with us. Like, if we still hold on to that baggage, it's still going to be like the vestiges of because what we're really talking about here, let's be frank, is bias. Yeah. We're talking about weight bias. It is, we know the science, we have treatments. I don't get why 1 and 1 is not 2. Like, the emperor has no clothes, people. So it's because there's massive bias across society towards treatment. Ian, you and I can acknowledge that it took you a long time to talk about your lived experience. And there are still spaces in this world where you have to defend those choices. But I want you to take away the term adiposity or obesity or whatever term you're using and put in the term depression. And you would never, ever have, Lady Gaga has depression and it's cool. And I'm not suggesting depression is cool, but I think we are in obesity medicine where we were in mental health 30 years ago or 40 years ago. And yet we have way more treatments than they had 40 years ago. So we're at the phase where we're literally sort of doing, I don't know if anyone saw the Netflix show Ratchet with Ryan, like, we're literally dunking people in water, basically, kind of the equivalent of what they did in like One Flew Over the Cuckoo's Nest or what have you. And we're doing it not just in non-legitimized obesity spaces, but there are legitimate clinics across North America that are, specialty obesity clinics who are still telling patients to work harder. And who still, studies show that obesity physicians have the same rates of weight bias as medical students. So, there's still this auditioning for treatment. You don't have to complete a preconditioned experience to get your hips replaced. You don't have to sign a contract to say that you'll take care of your cardiac bypass. But survey it in bariatric programs across this country, there are contracts that you must as a patient sign to say that you'll be a good patient and you'll take care of your new stomach. Like, I don't know about you, but if you lie down and let someone stick a tube in your throat and play, patty cake with your gastrointestinal tract, that to me is consent enough. That's a contract. No. So I think, sorry, I get very upset about this because I think that we talk around the subject and we never really call ourselves out. And I don't have a problem with being uncomfortable with my discomfort. Being comfortable rather with my discomfort anymore, because I think it's okay to acknowledge where we've gone wrong. And the fascinating part of that is that the biggest principle of medicine is do no harm. And yet we continue to spit in the face of that principle. So that's sort of, I think, our challenge.
Yeah. It's continual learning. We gotta be open and be willing to learn and adapt and change as we go along. And it's going to continue to change, I think, for the next while.
I would say not only is it learning, if I may, I think it's actual action. Yeah. So I think the learning is fine and it's wonderful, but I think that it's more about having those uncomfortable conversations or pushing boundaries about the science and forcing us to alter our practice, because the learning is there. It just doesn't. I'll give you an example. You have to cut out coffee prior to bariatric surgery, right? Do you know what the science is behind that?
No idea. I wasn't very happy about it.
There is none. There's no data. It's a 1950 study on like esophageal cancer patients. And it's the thought that coffee increases acid in the stomach. Well, if you're on a proton pump inhibitor, good luck. So I think some of it is these behaviors are from the 1960s, but the treatments we have now look nothing like that. So I just think, we talk, I'm a McMaster grad where evidence-based was hammered into us. And I think my challenge is, in the absence of evidence, you don't then rely on the continued harmful practice, right? So if you don't have evidence to suggest that coffee or sure, I think there's some first principles, absolutely 100%, but I don't think I'm not the person who believes we need randomized control trials for a parachute, if you will, but I think there's common sense. And then there's these odd kind of practices that we as a community on the medical side need to go, just a minute here, and stand up and say, wait a minute. And also where our patients have the absolute right to say, just a second. And so I think that there's a huge amount of work to be done. And it's why I commend this, make no mistake, I sit on some of the academic committees of Obesity Canada, but I would argue that the patient engagement committee and the people who are most affected by these practices, I think they're the most important voices at a table. Perfect example is the Obesity Guidelines. Mm-hmm. Great that we have guidelines, but if you read through the 400 pages of guidelines, there's not a lot of science, is there? Nope. So let's not, no disrespect, but maybe we don't call them guidelines, because guidelines imply that they are sort of evidence-based standards of care. And maybe the first page should be, let's be clear, like what the guidelines taught us, or at least taught me, was how little we actually study this disease.
And I've heard you say before that you spend your days explaining to patients that they have a disease, and then in the evening explaining to healthcare providers about that disease as well, right? And I think that's a summary of also what you just kind of said there, is like there's work to be done on both sides.
And I think there's a huge amount of weight bias among patients who say, I can do this naturally. I want to do this on my own. I see medication as a crutch, or it's a failure, or what have you. And then I go and talk to colleagues in the evenings and they're like, well, if these people would just, these people, I love that sentence. Like, if you want to piss me off, just,
yeah.
So,
and it goes to that like faceless, nameless, beige wearing cohort that we're presented as often in the media, right? I'm not going to have a frame. I'm just going to be a belly, and you're going to talk about me in this third person like I'm not really here in the room.
Right.
And that's a huge part of what we need to shift. And I'm an open kimono, as you guys, most people already know, about my lived experience. And my lived experience does include actually coming to you as a clinician. And I have to say, it was like a smack upside my head. It was like no other doctor visit I'd ever had. And it's what I needed in that moment. But not everybody has the good fortune of finding their way to a specialist or to someone like yourself that's going to say, take off the body bug, which dates me as far as when you and I first met. Like, you were like, take off some of these devices, stop and be kind to yourself.
Yeah.
And there's an amazing question from Lauren, who also has her hand up that I'm trying to.
Sorry, Lauren, can I just put you on hold for 1 second? Because I think one of the biggest solutions to come from, not just from medicine, I think doctors need to be more, dare I use the term revolutionary when it comes to treatment, and thinking and pushing and not trying to treat everybody, and treating patients where they are, and acknowledging there is no goal weight, there is no BMI, like none of these sort of numbers that we're setting, they're all garbage. So I think that there's that, and that's a problem for a profession that is trained to have absolutes and to recognize patterns. So it flies in the face of our entire kind of cultural zeitgeist on the medical side of things. And then I would argue that on the sort of cultural side of things, we need more Lady Gagas. So I'm pissed off at Oprah Winfrey because she has the largest cultural platform in the world. She is a woman living with weight. And what did she do? She bought Weight Watchers. Like, bitch, please. Really? Like, this was not the moment to do that. And so I have a real problem with it. So I think she had a moment to speak to weight bias, or to speak to the effects that this has had on her, or to talk about it in an honest way. Not that and make no mistake, I do not believe that everybody with adiposity needs treatment, period. Nor do, like, I think treatment is personal. I think patients have a right to refuse treatment, period. So I think there's that piece. I think there is health at every size. Absolutely. Because if your disease is not affecting how you move through the world, then great. That's awesome. Then good to go. So I think there's that. But I think we need more Lady Gagas. We need more people. I'm so exhausted. What's her face from the Us? This Is Us.
Oh, yeah, I know what you mean. I don't know her name.
Lori Metz, I think is her name. Anyways, I wanted to throw the magazine across the grocery store when she was on the cover of People, and it said, How I Learned to Love Myself. And I was like, oh my God, like, could you not just say, like, why don't you just like be honest about the amount of fat shaming that is in that statement? Yes. And so I think that we need to insist. I mean, like Megan the Stallion, amazing. Like, I think also even on social media, and I'm sort of following people in this space, and I noticed that a lot of these health at every size advocates, no disrespect, are super skinny dietitians. Like, sorry, and I don't mean to insult, but it's an interesting thought about and they're the not advocating, not dieting. And I watch them, you know, with their like beautiful wafiness, and I'm joking, like I'm the exact opposite of everything, and you know, doing these cute little videos about undieting and eating and intuitive eating and all this stuff, and I'm like, so I think we just need more big discussions that in forums where it's not us versus them, it's not medicine defending medicine, and like I just don't get this whole I'm the devil. And it's funny because I've reached out to many of these people in these communities, and some are fabulously welcoming and happy to have conversations with me, but many are, I have been compared, this was my favorite one, to a deprogrammer in the homosexuality community. I was compared to the deprogramming of homosexuality, which I, as a massive LGBTQ 2+ like advocate, I could not, it was the greatest insult of my career that I was told that I was likened to a deprogrammer in that space. And I was like, okay, first of all, we need to talk about what disease, like, anyways, it was just a whole issue. So I think there needs to be more unity across the aisle, if you will, some bipartisanship of medicine and culture. And I think culture has to step up and stop giving us, I mean, Adele is fabulous. Like, can we stop talking about what she like, and I'm not saying she looks fabulous. She looks fabulous in 2020. She looked fabulous in 2016. So I just think this discussion around these issues needs to be had in a much more informed way. And we need cultural champions who don't buy Weight Watchers.
Yes.
Sorry.
Yes. No, that's
now Lauren
I love
had a question. Lauren had a question.
Lauren, no, but all of that is really, really important. And I think you and I have touched on this in other conversations as well, that, you know, how did we get to this place where it's either or, like it has to be so black and white? I believe that you are a person who understands body diversity as well, like, and that body diversity should continue, whether I'm in treatment or not. It doesn't mean that I'm still going to come out looking like that ideal that diet culture is also telling us. I am in treatment.
Well, you're blonde, so you already are starting from a good place.
That's true. I have a lot of privilege. I walk through life with a lot of privilege.
This is not gonna happen.
But I love where Lauren was going with her question as well, where it's, you know, absolutely, I love all this. And again, even with our clinical practice guidelines, it's great. We'd be very naive to think we'd put out guidelines and that's going to change everything on both sides of the fence, all of those things. So one of Lauren's question here is about how do you have any tips for having discussions with this? Because it's very true. We can go in and we can be empowered or feel a little empowered and then get knocked out with one conversation with a healthcare practitioner that's just going to come back with the same old.
Sure. So a couple things, and this will answer Doug Earl. Hi, Doug. Awesome. Love that you kept your camera on, Doug. Not negative to anyone else, but I'm struggling with connectivity these days, Doug. So really appreciate it. Awesome. So I would say if you are a healthcare provider, how I talk with patients is, first of all, I ask permission. Like, I think that's number one, 100%. So keep that in mind from the patient perspective, because it literally mirrors it. And then it's interesting, and not to plug it, but I have a video that I made, because I used to talk about the hunter and the storer, and this is energy physiology. And I talk about it from a biological perspective. I am a geek. Oh my God, that's adorable. I love that you turned your camera on, Lauren Cates. That's a riot. Although we'll talk about your fake background later, because I think you're an authentic human and you don't need a fake background. That's all I'm just going to say, because you're fabulous. So celebrate the hot mess. Absolutely. Awesome. that being said, I would say what I do is I talk science, because people can't dispute science because it's not a belief. Science is a fact, right? The earth is round. Like, so I sort of explain, and if for those of you who are interested, and in fact, when I have residents come through, I say to them, I need you to do a 5-minute spiel that's going to explain to patients the physiology of energy regulation, which, to Teresa Mosher's point, doesn't talk about weight or obesity or fat tissue. It talks about energy regulation. So how we lose and gain weight, and explain it in a scientific way. And I have this kind of video that I talk with patients about. And sure enough, I do a couple 5 minutes, show them the hunter and the store in their brain. And then I send them the video to watch. And it really helps them conceptualize how we lose weight, how medications work. And then, for example, patients go on medications, and sure enough, they have variability in terms of response, which is hugely genetic. So whether you lose 100 pounds on a medication or 5 is hardwired into your genetic code, because remember, this is not a one disease fits all. It's probably 50 under a single umbrella. And then the body goes into starvation response. And it's not that the drugs aren't working again, it's that the body, remember, obesity is the brain thinking it's starving, and so it stores fat. So when you lose weight, what are you doing? You're perpetuating the starvation myth. And so the brain's going to keep fighting to get back to not starving. And so that's why weight gain happens. And so the worst thing to do in that situation is to reduce caloric intake even further, like sort of the Bernstein method of, if you're on 500 calories and that's not working, let's drop you to 3. Like that's a great idea. Anyways, right, you're all shaking your heads, but yet everybody's joining, like, don't get me started. So I think there's that. So I think I explain it from a physiological scientific perspective. Now, on the patient side of things, I think you can, like, one of the things that I have found, particularly in COVID, that works beautifully is humanity. So you can be human. So I'll give you an example. I would say right now we're talking, and you can see this isn't an act. This is just me. Absolutely. And I think that being yourself and being authentic and showing who you are to your clinician, albeit very frightening and somewhat vulnerable, can be very powerful. Because not only does it help to break through their barrier, but it will help show you who that person is. So for example, if a physician approaches you around weight without asking your permission, you can stop them and say, you know what, totally appreciate that you feel this is something that you're concerned about. And I know that you have my best intentions. However, I already know that my weight is an issue. I don't really need to have this discussion unless you feel comfortable engaging in a scientific-based treatment option for me. But if you're just going to suggest to me that I join Weight Watchers or I really start taking my weight seriously, I don't think we need to have this conversation, because I want to assure you that I've been to that mountain many times. Now, on that front, if you want, I would love for us to learn together if you feel that you're up to this task. And isn't that an awesome way to invite your physician to be better? Now, you don't stand to lose anything with that, because the doctor will either take up the cause and say yes or no, or the doctor will acknowledge that they, quite frankly, have no idea what they're talking about. That's another option. And then you have a conversation. Well, if you're not comfortable, do you know anyone else that you could refer me to? Because that's an option, number 2. So it's a conversation, but you can invite the conversation, and you as the patient can delegate the terms of the conversation. And again, I want you to think about it. You know how when you leave the office and you go and talk to someone and you say, God, I wish I would have said X, right? So say that. And the interesting thing is, unfortunately, my patients are very well experienced about what they wish they would have said, because by the time they have that conversation, it's probably the 30th time it's happened in any case. And I think that that's definitely sort of a possibility. So I think that there's my recommendation to patients is to, if they're interested, to invite the conversation, but to maybe check who is treating them, because I think they can gauge that doctor's knowledge base and that doctor's comfort level with this. And again, not necessarily that doctor's experience, but I think that, as long as the physician is willing to learn and to engage, then great. And I will say I've had patients go to see their physicians and say, I want to talk to you about this medication or this surgery. And the physician's like, I'm not really comfortable with that. And the patient's like, well, how would you feel about getting comfortable? Like, and if not, is there a place that you can go to get comfortable? And in fact, I've had 2 calls this week from doctors who were like, my patients tell me I have to get comfortable with this. And I'm like, great. I'm happy to sort of talk to you about how to do that, because realistically, this is definitely something that you're gonna see in your practice. And, and you have a potential to make a huge difference, not just in the individual you're treating, but in changing the culture of the field that you practice in.
Ian and I spend a lot of time thinking about this too. And, not to paint everybody with one brush, but we also know that as we're talking to our cohort of patients, we want them all to be advocates for themselves at a minimum, but hopefully also for our larger cause. But it is hard. As a person who has lived in a larger body, I was used to not wanting to take up space or rock a boat or draw attention. So it can be an even more intimidating space in a healthcare setting to really own this. So that's why we're so excited to have these communities and these conversations so that we can empower patients to know that you can, at a very minimum, you can say, why do I need to be weighed today? And I'm going to take a pass on that. Like moments.
Not even why do I need to be weighed? No, thanks.
Yeah.
Not doing it
there. And I want to give Lauren, I'm going to give you credit, lady, and you might want to come off mute for a second too, because you are a little Lady Gaga out there as well, because you have shared stories, and I want to make sure you're okay with sharing this one, where you kind of did get to the end of your tether and you snapped and said, how am I supposed to do that? Right?
Yeah. Yeah.
And Lauren, you don't have to share that story now that we put you on and everyone's going, share.
No, she's one of my advocates that she's mostly comfortable, but yeah, I just wanted to call that out.
Fine. It was a situation where, I have some medical issues that I've gone through, and I now have a hernia and I have diastasis recti. I think that's how you say it. 2 hernias, and my surgeon didn't want to fix the hernias until I had gotten my weight under control.
Under control, love that term.
Yeah.
And so I just sort of lost it, because it was already just such a mess, the whole experience of like almost dying from this surgery and like an ostomy and like everything. And I'm an open book, so don't even worry, I'll tell you anything, but it was just, and now you want me to get my weight under control, like before you'll fix what you broke. How the heck am I supposed to do that? Like my body doesn't work the same way as other people, my peers. I can't just eat less and move more and expect my body to react the way it's supposed to. Like, fix what you broke. And also, like, how do you expect me to even deal with this right now? Like, let's have the brass tacks here. And
that shifted your world, didn't it?
Being different.
And again, 2 things, like the idea here of, if this were any other like condition, like if this were cancer, heaven forbid, they'd be in there.
Yeah.
Right. 100%. The other thing is, I love the term under control, implying that it's out of control now. So I teach my patients, when a doctor says under control, my patient's response is, my weight is under control. I've been the same weight for the last 20 years. It's under perfect control. Like, I'm not really weight fluctuating, if that's what you mean. Mm-hmm. And I think the only challenge I would say, and Lauren, as you've experienced, is there's this weird kind of like, how do we, and I appreciate, super frustrated, right? Like, you're pissed, and rightfully so, but how do you like you and I both know that you catch more flies with honey than you do with vinegar. And so the problem is that you're frustrated, you're have fingers pointed at you, and you point them back, and all of a sudden it just becomes a pointing match. And so how do we have conversations then that go above and beyond that is the bigger question. And it's, and again, sometimes you're just going to find a couple of psychopaths who aren't going to help you, and that's totally fine. And I hear you, and I think it's important to know that. I'll give you a perfect example. This year in COVID, I was exhausted of hearing about patients who needed their knees and hips replaced, who were told at 75 years of age, you need to lose 100 pounds before I'll fix your knee. I'm like, so basically this person's going to die. Like, this is not going to happen. So I approached 2 orthopedic surgeons who, if you can change an orthopedic surgeon's mind, you can change the world. Just so you know, this is a joke in medicine, because orthopedic surgeons are very, like, anytime you saw a limb off comfortably, you're a bit of a psychopath. Like, let's be clear, like, that's weird. So I approached 2 orthopedic surgeons and I said, hey, do we have any science on these 100-pound marks? Like what is this like BMI thing? Because if we're just losing BMI, like if you're replacing a knee and the patient carries all their weight centrally, there's no fat tissue around the knee. I just don't get it. Like, can we talk about location even, or just something to that effect? Like, what is it about these numbers that you guys are hooked on? And they're like, well, complication rates. I'm like, so can we talk about the data? Like, is there evidence? No. I said, so there's no science to show complication rates or what have. Okay. And what if the patient accepts that that complication rate is a reality? Like, you could even, dare I say it, have them sign a waiver, like, whoopee. Sure. I said, so understand that medicine is all about risk and benefit, but you have a 75-year-old being told that they need to lose 100 pounds. So what we did was we created, it's called the Get to Surgery. And it was a program that literally surgeons would just refer us, the patient, and we would put them through an online program. It explains their disease, it explains treatment options. It was for patients who wanted to go on legitimate medical treatments to drop their weight by 5 to 10%, which is what the science shows, in the hopes that we would maximize their health and improve their outcomes after surgery. And more importantly, we would change, my thinking was, let's change the culture of medicine. So for example, patients like you, Lauren, are not then said, go get your weight under control and then we'll fix you. And it's like, wait a minute, I'm the patient. I'm here now. Why do I have to manage this disease on my own in order for you to step up? That makes no sense. And so I think those are the conversations to start having, of this idea of, okay, fine, you want me to take care of this. I'm curious, we would never let patients manage their own blood pressure on their own, or their own, like, other things. We are wanting to be involved in those spaces. So I think just having the conversation, as you've beautifully said, like you said, like, look, this isn't like the one thing that I'm having a problem with. Even if we want to play your devil's advocate argument, I didn't do this. So this is actually something you as a surgeon could do. And so I think even asking the question of, can you explain to me what the block is? And when they say, well, you need to lose 100 pounds. So what made you think of that number? Like, I just need to know the why. And because part of the challenge is physicians speak science, right? So what you want them to do is engage in that science brain type thing. And the other thing that allows you to do as a patient is kind of realize, look, there are places in this world you're just not going to change. Mm-hmm. Like maybe that surgeon did change their mind, but maybe they didn't. And if they didn't, then the next question is, thank you very much. Can you send me, I need a second opinion. I need a surgeon who's going to take care of this.
I always find that conversation interesting because, like, what you said, there's no science and they don't have the data to support that decision and stuff like that. And when I get those patients coming and reaching out to me and saying that they've experienced this, they've been told they need to lose their 100 pounds before they get their knee surgery or whatever it is like that. And we've asked people, and they say that maybe it has to do with the anesthesia, going under and something
No,
like that
bullshit.
complication. But here's my thing. Then
Bariatric surgery, we
go to
intubate and put patients with BMIs of 80 to
Well,
sleep.
that's my thing. The doctor says, when you lose 100 pounds, we'll do the surgery. How are you going to lose 100 pounds? Well, here, we'll refer you to this bariatric clinic. So you're not going to do
You're
the surgery
gonna
on
have
me,
yeah.
but you're going to send me to go have a surgery on,
Right.
what's the difference?
But I think what you want to do is have the conversation, because the conversation may go like, we can fix the hernia, but it runs the risk of happening again in this area. And the question that you ask is, what are my risks? And what if I'm willing to take that risk?
Yeah.
Right? Because you can do a mastectomy, but it runs the risk of infection or this or that. But I'm willing to take that risk. So I think that I'm not suggesting a solution here. And as we can all agree, this is definitely a bigger issue. But even just having the conversation, purely, if nothing else, that you walk away knowing that you because as a patient, you continue to feel victimized. You're like, I need to stand up for myself. This is ridiculous. So I think if nothing else, that comes of it.
Lauren, my friend.
Oh, I just wanted to say I'm going to a plastic surgeon today to go ask about this. So this has been very empowering. I always
Nice.
You, Allie. Thank you.
Yes.
Awesome.
And I think you know what to do. Have the conversation about it. Ask the plastic surgeon, do you have a specific weight that you only operate on, or like those kinds of things? And what is that? And, can you explain to me the risk and the benefit? And as a patient, I'm happy to make a decision here. Like I acknowledge, I'm not, I'm not, here are my expectations and all of that. And I think that, so
we want everybody in the room to make informed decisions, right? So that's part of the goal. And I've said this before, and I will say it probably to the very end. Everyone is entitled to their own opinions, but not their own facts. So if you can, as Allie was saying, also just kind of root it in facts and get them back into that science brain, I think that's super powerful.
Yes, I think the one last take-home message I will say at 9 o'clock, because I do have a patient waiting, is can we acknowledge that, yes, there are spaces where it's an us and them, but not every, I understand that my profession has a lot to answer for, and I understand that we have done wrong, but, and we are so not perfect. In fact, I would argue we are in medicine to try and fix our messed up lives. It's not working, but that's fine. But I want you to know that on behalf, and I'm not speaking for my whole profession, but maybe I am, we want to be better. And if we don't, then we have no business being in this profession, but we want to be better. And I cannot accept the fact that there are people who intentionally mean to harm a patient. And if they are, then that says more about them than it does about you. And so I think that that's key. I've had conversations with patients who have interacted with other bariatric experiences and said, God, I felt judged. And I said, doesn't it suck for that person to be in this field and to have that attitude? Like that must be torture for them. So I think I just want to remind you that, and I said this to a patient the other day, I'm like, I'm one of the good guys. I swear to God, maybe I'm not 100%, and maybe I do screw up and say the wrong thing and act however, but I want you to know that my heart and my intentions are definitely in the right place. So I guess that's what I'll leave you on, is that, I think that less of a us and them approach of big, bad, ugly medicine judging me and me having to, I think sometimes we see advocacy as us like fighting the man and burning it down. And like, I see advocacy as sure, get pissed off, but have conversations that move the conversation forward.
Yes. Ian and I did some amazing advocacy training, and that's what they say as well, is like, if you can't do this without being upset or overly emotional, then you're not in the right position to do advocacy. It's about that middle ground. And I think that's a great way to surmise kind of all of our conversation today. And, you know, the topic today was innovating health or obesity care in Canada. And that could have been talking about telemed, that could have been talking about tools and resources, all those things. But I think you've brought a
We
very
didn't do that, sorry.
No, I love that we didn't. I love that we didn't, because I think it is far more salient to root it in our humanity and about having the conversation. Stay in the room, get a little uncomfortable. When I first started saying I was volunteering for Obesity Canada, the word obesity felt like knees and elbows coming out of my mouth.
Bad word.
Right? Like
Adiposity Canada.
Yes. Maybe.
AC.
Yeah.
Adiposity Canada. Adiposity is Latin for fat tissue.
Perfect. Like, and that's just it. We need to make space.
Even like I have adiposity.
Yeah. Yeah.
Genius.
We need to make space and grace for people to change their behaviors. That's patients as well as healthcare practitioners. So I love what you're saying. Not everything needs to be guns hot coming in. So I want to wrap it up because we went a little bit over. Yeah, for sure. I want to thank you so much for your time today, Ali, and everybody else who is able to join. Really love these conversations, want to keep them going. So to continue the conversation, please join us in either OC Connect Pro or OC Connect. Feel free to find Ian and I along the way. We want to keep these conversations going. We will have another one of our connected conversations in September on the 28th, when it's going to be talking about fighting for care and how, again, weight bias and discrimination are impacting.
I'm sorry, I've got to go. I've got a patient.
That's quite all right, honey.
Bye,
Thank you so much. Everyone else, take good care of yourselves, and we look forward to continuing the conversations.